Great. Thanks, Bernie. Thanks, Dia.
James, can we start? I think there are 5 of them.
Yep, let's get going.
Okay,
Thanks.
Dia will start with the opening prayer now. Morning. Oh, Rafael is joining. Good.
Good morning, everyone.
Good morning, Dia.
Good morning, everyone.
Hi, Dia. We can hear you. You're breaking up a little bit, but we can still hear.
Okay, before we start the program, hello, can you hear me?
You're breaking up quite a bit. What about others? Can they hear Dia, or is it breaking up?
She's breaking up, and it's taking like some seconds to.
Bit of a delay, yeah.
Yeah.
Before we start the program, before we
You
start
didn't talk, but we are
training,
listening to you now.
yes. Before we start our program, our training program, you probably say. Hello. Hi. Hello. Okay, I'm using Benny's speaker. Okay, good morning, everyone. Before we start our training program, let's come before the Lord with a word of prayer. So let's all pray. Dear Heavenly Father, we thank you for this wonderful day. We thank you for the air that we are breathing right now. We are grateful for you are our God, our Almighty God who provides, who wakes us up in the morning, gives us strength to do our work, to go wherever we want to go and be here today. Father, we ask you in the name of Jesus to lead us and guide us. Give us knowledge, wisdom, and understanding as we partake in this training. This is our humble prayer in no other name but in and through the mighty name of our Lord Jesus Christ. Amen. Thanks.
Thanks, dear. Okay, James, maybe I'll just start with a couple of few remarks, and then you can start we can start the session. Okay, good morning, fellows. Can you all hear me?
Yes, very clear, Bernie.
Yes,
Okay,
good morning.
Good morning, all. Thank you once again. Thank you for this. I think this is the final session for this year. We'll continue next year, more virtual sessions. But I think for this year is the last session for December. Okay, this session will be on outbreak investigation. We were supposed to have it last week. Unfortunately, due to connectivity issues, most fellows didn't turn up. So we rescheduled to today. So we welcome you to this session. Okay, a few of our faculty staff who were supposed to be with us during this session to help with the presentation are not here, but James is here and me. We can go through with you all during this session, and Celeste can also assist where she can. During the session will be more interactive. You will have a lot of discussion, breakout rooms for discussions based on your experiences out in the field. So we will learn through more discussions and few slides to just for basic background knowledge on the outbreak investigations, what we do during outbreaks, what are some of the objectives why we're doing outbreak, and steps involved in outbreak, and all this we will learn today. And then at the end of every event that you partake in outbreak investigation, report is the last thing that we do. So during this session, we'll go through with you all in this session. So we welcome you on this session, and we can start our session today. So with the opening, James we will do a Mentimeter quiz. Oh, Celeste, sorry, James, if Celeste can introduce herself to the fellows, if she has sent, or if the fellows have not met Celeste yet.
Thanks, Bernie. No, I haven't met this group yet. I did dial in last time, but we didn't go ahead. Hi, everybody. Really nice to meet you. My name's Celeste Marsh, and I started with the program just a few weeks ago. I'm an epidemiologist. I went through the Australian program, the MAE, a few years ago now, and I just come back from PNG a couple of weeks ago. I was working over there with WHO on the COVID response, so that was really great experience, and it meant that I understood the context a little bit more and met some of you, or some of the team anyway, the FETP team. So really looking forward to working with you. Thanks.
Thanks, Celeste. Okay, presentation for today is just a brief outline for what we will go through during this today's session. Okay, after the Mentimeter quiz, just a few slides to go on the objectives, learning objectives for this session, and then from there you'll break out into session with some guiding questions for discussion, and then presentation, introduction of key terms used during outbreaks, objectives of outbreak investigation, why do we conduct outbreak investigation, case definitions of outbreak, and then steps involved in an outbreak, 8 steps. We'll go into that, and then we'll have another breakout session for case study of an outbreak, and you discuss and present your discussion findings, and then communicate your findings, and how to do a situation report, outbreak report, and then Q&A session. Then we close up with another Mentimeter quiz, and then few reminders. Okay, let's go.
Alrighty, we are going to do a Mentimeter. And I can't remember, I think most of you are familiar with Mentimeter. It's our online quiz. So if you go to your chat, you will find the link to Mentimeter. Click on that link in the chat box and put in the code. And I'm just going to share the screen now, and Bernie will step us through this Mentimeter. Should be a fun one. All right, just sharing screen now. Okay, so join quickly and you can leave the suggested name, or you can put your own name in if you would like. And do let us know if you're having any problems connecting. You can use your phone if you want. If you have another device that's connected to the internet, you can use that if you would like.
www. Sorry, I'm talking.
You can just Google menti.com as well if that's easier. So MENTI, menti.com. But if you go in the chat, you will see a hyperlink that will take you directly there. So it looks like we have 4 joined. We need a few more. So how's everyone doing joining the Mentimeter? Put your hand up if you're needing some help to get in.
Morning, James. Sorry for my late coming. I was just in the middle of another trick just completed, so I'm ready now. Thank you. Sorry about this for being late.
No worries, Dr. Gilbert. We're actually just getting started. This is our first Mentimeter to kick us off the session. So we have 5 people joined. Let's give it 1 more minute and then we'll get going, Bernie. There we go. We got 6. That's good. All right, let's get started. And you can still join at any point, even though we get started. You can still join if you're still trying to connect. All righty, we ready to go? Get ready, because the faster you answer the question and you get it right, the more points you get. Okay, Bernie, over to you. We're going. So look on your device and answer the question, what is an outbreak? So what is the definition of an outbreak? You've got 3 options to choose from. Click the one you think is correct. All right, look at that. Everyone got that one correct. Everyone who answered.
Okay, that's good. Who's the fastest we see?
Whoa,
Okay,
Ralph
Ralph.
and Dia up there.
Yeah.
Well done. Ralph gets in fastest. Okay, we ready to go to the next one?
Next one. How do you know if there is an outbreak or a public health event occurring? So we have a couple of options there. You read through and select one you think is the most correct. I also answer this. Well done. You three, it's all of the above methods. Any reports coming from from the surveillance system that you reviewed, or reports coming from the health workers, or reports from other agencies, or media reports, or from rumors, it might be an outbreak. You need to verify and confirm. So all of the above. Okay, next.
Whoa, Dia's right out there and Scorpio.
Okay, next one. I didn't do the first one. What diseases or public health events can cause outbreak? Okay, we have it's multiple options. Yeah. So those three diseases can cause outbreaks. Okay, well done. Good. I didn't do it.
Whoa, Dia's out the front. Let's catch Dia.
What do you do first, the first step when you receive a report of a possible outbreak? We have 5 options there. What's the first step? Table.
Oh, it's pretty close. This is our last
Okay.
question, I think. 6 of 6. All right.
I went out of the quiz.
Whoa, everyone did that one fast. Okay,
It's false. Sorry, I just.
final leaderboard. Bernie. I mean, Dia. Well done, Dia. All right, so we have another one of those coming up a bit later. Thanks, Bernie, for putting that Mentimeter together.
Okay. I think I will. Okay. James, you sharing the slide?
Yep, let me bring up that
Yeah.
PowerPoint back again. All right.
Okay. Just respond to Dr. Gilbert. It's going so. Thanks, Dr. Gilbert. You can go for the meeting. We'll continue. Okay. James, move next slide. Okay, this is the learning outcome for outbreak investigation. Outbreak investigation is one of the core domains in the field intermediate program as well as in the advanced program too. So learning objectives for that domain is, we don't expect you to learn everything during this session. This is just an introductory, but at least by the time you complete the intermediate program, at least you are well equipped with better understanding and knowledge about outbreak investigation. So in this outbreak investigation, the objective is to understand the definition of terms used in an outbreak: cluster, outbreak, epidemic, endemic, and pandemic, what these terminologies mean. But we will not go in depth in all the terminologies. In this session, we'll focus on the outbreak, epidemic, and pandemic terms. And then describe the steps involved in an outbreak investigation and understand the steps when you write up an outbreak report. So these are the three main objectives of outbreak investigation. Next. Okay, before we go into the main presentation, James will break out, put you in groups, and then you will discuss based on your experience sharing an outbreak. So we'll share some guiding questions.
Yeah,
and then
thanks,
based on
Bernie.
those questions, you do the discussion. And then Mark, a team. James, let me answer Alois first.
Yeah, sure. No worries, Bernie. So what I'll do, we'll have two groups. I'm just going to try to get into the chat box the document that we can all fill in the groups, our guiding questions. Just give me 1 second. So that should have come through the chat. You'll see a Word document. And what we need is just one person in each of the breakout groups to open that Word document. And we're going to fill in this. We're going to go through these questions in our discussion. And we've got, we'll probably have about 30 minutes to go through this. We have 6 questions that we're going to discuss as a group. And the idea of this is to get your experience on doing outbreak investigation. So a lot of you probably have had experience investigating outbreaks, and we want to have a bit of a discussion to start off with, to understand the different types of outbreaks you've been involved with. What was your role in investigating that outbreak? How did you go about doing it? To kind of describe the steps that you went through when you did an outbreak investigation. What sort of public health interventions did you do? And what were some of the key challenges you experienced when doing that outbreak investigation? So we'll break off now into our two groups. And I'll just check with Celeste. Did you get the Word document through the chat okay, Celeste?
Yeah, James, I've got it. I've downloaded it.
Fantastic. So maybe we'll have Celeste in one group just taking a few notes from the discussion, and I can be in the other group. I have the document in front of me. So let's break off into our groups now.
Hello. Hello.
Hello, George.
Hi. Sorry, my network here is playing up, so I'm just kind of checking out if I'm connected or not.
Okay, good one. Me too. Just some cuts on the, the sound. That's why I'm not connected as well. I just unmute myself.
Okay. You are
Joachim?
Joachim.
Yes, yes.
Okay.
NBPH.
Yes. And we are three of us in the meeting. That's Julian.
Julian,
me and
you
Julian.
and myself.
Okay.
So you check on Julian.
Okay.
Is she? Okay.
Yes, I
Is she,
can see her mouth moving, but I
put
can.
on?
I think she must be trying her best to get on. Hello, Julian. Hello, Julian. Hello, Julian. Hello, Julian. Can you get me? Oh, yeah, there. Okay. Yeah, just went off. Hello, Julian. Julian is still. He went off and.
Yeah, probably connection is problem as well. So we just check on her.
It must be having a connection problem. I think only two of us left now. Dia just came on and then he just left.
Yeah. So George, so what are we supposed to do now? Can you have some?
I think we'll discuss about outbreak investigation experiences, how we go about doing outbreak when we first receive any outbreak report or any alert about this is outbreak in certain areas or communities.
Sure. Okay. So probably you can
Just
start off
about.
and then I can share my experience.
Oh,
as well.
okay. Okay, I'll just give one experience about the outbreak that we went through. I think that's a pertussis outbreak in one of the nearest communities. So that was in November last year. We had at the provincial level, we received a call from a health center that there was a whooping cough detected at one of our nearest health facilities. So we sent the officer and said that you go into the community and find out if there are other children also having the same symptoms. So she went into the community, go straight to the particular patient, house of that particular patient, and found out that there were also other children who were also having the same cough. So she came back and said that yes, we have a few number of children surrounding that initial case. They are all having the same kind of cough. So we mobilized all our team, the investigation team. This is control officer, the pathology staff, the clinician, and then we went to that village got the health facility staff, and then she brought us to the initial case where she went and found out, and then we started collecting the samples of those suspected cases. Then we sent the specimen to the CPHL to establish a case definition, like doing a test, and then to found out that whether it's truly hepatitis or other disease. We waited for lab result, and the lab result returned back positive of hepatitis disease. So we mobilized all our resources, medicine, vaccination, our awareness group, and then we went there and did overall. We also worked with, while we were mobilizing our community resources, we also asked the facility staff that any other children within the nearby villages that are suffering from cough illness, you let us know. So she went around and then found out that these villages are suffering from such cough. So she let us know, and then we did a whole program to cover up all the nearby villages in those areas, and we did mass immunization as well as treatment to those that are suffering from cough. And then we waited for 1 month to see if the cases are coming up or not. We asked the officer to go and look around, and nothing was happening. So we were satisfied that we controlled that hepatitis outbreak well in that particular community.
So you managed to control and disrupt the
Yes.
That's a very nice experience. Oh yeah, okay.
Yeah.
So that's a good experience. Okay, so
So
for me,
like,
yeah, you go ahead. You continue.
No. I mean, like how the information was relayed to us, and then we went and carried out the investigation and how we mobilized things. Then I came back and realized, I mean, like look through the process of how cases were managed. Almost we did what outbreak management protocols set in place. We almost did exactly what we supposed to do. So at least we were able to manage and control.
Yes, that's a good
Yeah.
one. Okay.
Okay, so now your turn.
Okay, for me, I'm 1 year in the position now as a provincial disease control officer, and I've experienced an outbreak. Last year, and it's regarding the one of the outbreak within the community in one of our district in Kokupo. Actually, there was a child brought into the facility in town, and was found that the child was partially paralyzed. So we were called up from the facility level. They called me up to do an investigation on that child. So initially, we started off from the family itself. It's like probably 200 kilometers from where the facility is. So I actually went there with another officer. So we actually investigate the case by actually verifying the case through the medical record attained from the facility. Now, we collected a sample, a stool collection from the child. That was in the morning. So we took the specimen to the lab in our provincial hospital to test the stool, and we were asked to do another collection of the specimen the following day, just to verify. And then we brought the specimen to the lab, but we found that we're supposed to there was a complaint actually from the child that is paralyzed because of certain disease that caused paralysis to the child. But after the test was done, we found out that the test was negative, and there was no good report from the lab telling us whether the result was adequate for us to determine whether the child actually was initially have that disease. So we actually canceled the doctors actually canceled the whole investigation because there was no good result from us. But from the experience, we see that there's going to be a very good report from whichever source that we attain, so we can actually capitalize on that to verify, and then we investigate and we control the spread of the disease. So my experience was not like actually control the whole spread of the disease.
You were in the process.
And that actually tells us that certain information that we need to attain is to adequately supply us what we need to further investigate and do our through our resources that we have. But the report was well done to the PHA, and actually it was not the disease that we were trying to verify. So that's a bit of experience. But from then on, we try to make sure that sources that we attain our reports, and coming from those sources has to be true, so we can further our investigation from there. So it's a bit different from your experience, George. From our experience now with the COVID-19 now has guided us into doing a lot of investigation in terms of cluster outbreaks in our areas and in the districts that we get reports, because we have district health coordinators and a few facilities OIC. They supply us with vital info. Those information that we can further our investigation and utilize our resources to well manage any outbreaks in those areas.
Yeah. It also depends on quality of specimens that we collect.
Yes, you're
the
right.
technique how to collect the quality specimen will determine whether we are dealing with the right disease or not, because I have seen some of my officers, we train them to collect the COVID-19 specimen. Some of them are really scared to put the sticks right into the to collect the nasopharyngeal swabs. They just like tip of it, and then they just quickly remove it. And no. You have to put the sticks right there, right to the back, and then you have to actually see tears coming down from the eyes, and then you will know that you have already hit the right point. That one you are just lying, and because of such actions, we are receiving negative results. These are some of the reasons why, though we have disease outbreak, but when we are receiving negative results, that could be some of the reasons.
It could be like the techniques, especially the technique on how to collect, samples from patients, has to be done well. So we get a quality specimen, so we can get a quality results from those specimens that we bring over to the lab for pathology. So that could be one contributing factor in terms of really identifying diseases through the technique on how to collect samples. Yes. And with COVID-19, you are right, my brother George. Because yeah, I've also trained few staff in the facilities, almost 127 staff, healthcare workers. But now, well, they could collect the samples from the nasopharyngeal. So before we used to collect the oropharyngeal one, but because of all kinds of debris contaminating the specimens, so we haven't received any good result from the oropharyngeal swab. But for Dasal now, it's okay. So far, so good. But it's only the technique, some, health workers, they're still afraid, patients might slap them. So that's the kind of, that affects our.
That's true. That's true. Like some of the patients, if they see someone who is like the people who are coming with higher ranks, they are always panicking whether they are doing the right thing or not. So people who, I mean, like grassroots people, they just confidently they do the collection with confidence. But when people with higher ranks come in, some people their hands are shaking every now and then. So no, no, no. They these people
Also sweating.
they are under your care, so you have to be confident and you have to do the right thing. When you are shaking, you are already giving out the message that you are not confident of what you are doing, and then that your clients will lose trust in you. So you have to be careful when you are dealing with these kind of people.
And I think, George, the best thing is to explain to them prior to the sample collection.
Yeah, that's
explain
it.
to them, so whatever experience they go through when you're doing sample collection, they would understood that you have explained well to them.
Yes,
So these are the things that we need to improve in our sample collection, especially for whatever outbreaks that we would like to investigate.
Tips to step to collect specimen, and then clients must be cooperative.
Yes, and probably how to handle specimen as well due to temperature, because we need to travel distances to the nearest laboratory. Then we need to store them in the right temperature and whatever equipment that we use to store. We have to do all these things well, so we can get a good result in no time.
That's it. And we should have a regional laboratory where we should get our results quickly. But I don't know if we have a regional. I mean, like those, especially with COVID-19 genotyping stuffs going out for genotyping. Our results are not coming back as quickly as we expected. So those are some of our setbacks in our decision making.
Yes.
Whether we are dealing with because now that they are saying Omicron is coming, then how so are we going to know that we are dealing with Delta or we are dealing with Omicron? And those are some of the things that is really those are challenges. So I suggested it. I think in the one of the WhatsApp group, I suggested for regional those genotyping setups, so that all our specimens requesting for genotyping needs to make those things results available quickly as we need it, so we can make decisions and isolate those cases quickly as fast as we can.
Yes, you're right, George.
That's what I just suggested.
Yeah, it's from our experience, George. That's why we're trying to share some experience to lighten our responsibilities in the field. For example, what you've just mentioned on genome sequencing, the turnaround time is very poor. For me, in distribution, the latest one would be around 1 month plus 2 weeks. We receive our results from Melbourne. That we have almost 39 positive case from Delta variant now in the province. So
wow,
we propose for getting one of our labs in the country so we can get our results quickly, reducing the turnaround time. and then we can do contact tracing immediately after we get our results. There's no use getting our result 1 month after, and then
1 month.
by then the spread
Truly,
would have gone.
brother, for us here in Gulf, all our positive results were sent for genotyping. We haven't received any feedback from Melbourne. That's really worrying us, and we asked the people at CPHL, have we any results for us at from Melbourne? And they said, if you are not receiving anything, then that means your results means that there is no data variant, and no, that's not a good excuse. Every time we send the batch of specimen for sequencing, you have you have to send us some document that all your tests are negative, or you detected, or at least 1 or 2, or at least something like that, so we know. At least some form of notification must come back to us. When we are not receiving anything, you are just putting us in. So we just tell them that, please, yeah, at least some feedback that we get, your results are coming back, or all these kind of things, so we know what's happening. And our lab men just got frustrated, and they had a lot of argument over the phone. I was just standing next to him, and so that's what we did.
Probably just because your communication, in terms of networks, is okay, or that's why you're not receiving your results on time.
No, we are sending, we are picking up our samples and dropping off at CPHL, and our staff going there to drop off the specimen. They are asking them, any results coming back from Melbourne about our genotyping or all these results, and then they would say no, the results are still pending. So the last time the lab people went for the workshop, they found out that they asked our lab person, OIC pathology, asked the CPHL in charge, and she says, if you are not receiving any result from Melbourne, then you must know that you don't have a Delta variant in your province. Our lab person said, no, at least you have to send us something that you are negative, so we can give assurance to our POC team. They are always asking me about whether we have Delta variant or not, and I'm always telling them that no, we are yet to receive results. And now here you are telling me that if I am not receiving anything from Melbourne, it means negative. This is a cheapest explanation or reason that you are giving me. So they had argument.
Okay. So, well, for integrated, we have received all our positive ones and also negative. So that explains clearly that our result, and even they also send the copy of the CIFs we sent. So we receive all those results. So it's something motivating us to work real hard to at least to more contact tracing and encourage our co-trials in facilities to do testing in the websites.
Yes. It's supposed to be like that, but I don't know. I just don't understand this. Our pathology officer and people at CPHL. So for Gulf, we still need to detect Delta variant, and that's from the CPHL boss Mary.
Yeah. So I got something to. We want to say something with you in terms of governance. Well, if you have a break in the province, and if you want to you want to verify actually by going to the community, or where the case is or the report comes from, then your site law administration no supporting you no resource na funding always lalo goal facilities or whichever community. Is that something that you face challenges with, or
Oh,
then probably I can explain in my in my terms on Eastern Britain. So those are the
yeah.
challenges you can use.
Yes. For us, we do have a very challenging, and then to access the HSIP funds, it's another brick wall that we every time we hit, and then that part of the brick is now weak. We penetrate, and then we get funding. you understand what I mean?
Yeah.
So our response activity is really slow. Like emergency is emergency. Like we need finance people to be present every now and then. Whenever we receive a call that there's a case detected from this area, and we said, okay, mobilize resources to go to this area. And then they would ask us again to collect the quotations and all these things to submit. And then so when we do that and then submit, instead of taking at least few days to get these things done, it takes like 3 to 4 weeks to attend to those calls coming from
Yeah.
villages and something like that. So it's just really killing our moral. And then when we go late to those particular villages, the villagers will get frustrated, and then they will ask, we were expecting you people to come like this, and what took you so long? Why are you coming? If you are not going to come, just simply just don't come. These are some kind of unnecessary feedbacks we are coming because of such response coming from especially from the admin. That's really killing the moral of the RRT group. So in fact,
Yes.
it's true. It's not. I thought that it's here in Gulf that we are facing such challenges, but if you are feeling that it's kind of, yeah, so it's kind of maybe it's throughout the country. Our RRT response, the name rapid response, does not really match this response. When the message comes in and then they expect us to travel within days, or get ready and then move in to respond, and then when things are taking to, let's say, 3 to 4 weeks to get things ready and go, that's not rapid response from observation. So
Yes.
our
George, I
people
think
in the administration, those people who are in the key position of ensuring that financial resources are made available for people to move out, these people are not alerted. I mean, not alerted, but what's the right term? I would say they are not tuned into our calls. So those are
yes.
some of our setbacks. Why our rapid response slow in rapid response activities in our province. So some of I think I would say that's our major setback and challenge for a rapid response activity in.
Alrighty, I think we're all back now. The two groups have rejoined.
Okay.
So we're all back together again. So hopefully that was a useful breakout just to get a bit of sense on the depth of experience from the group. And I think it's probably worth just doing a quick recap of the two groups. Perhaps Celeste group, do you want to go first with just a quick overview of what you talked about?
Yeah, thanks, James. Look, we only unfortunately had Matthew. We had Julianne for a short time, and then she unfortunately dropped off. So we had Matthew, and so he got bombarded the whole time and gave us all of his stories. But luckily, he had a few outbreaks to talk about. I won't make him report back because he did all of the talking in the group. Bernie, did you want to report back, or are you happy for me to? Because I took notes. Matthew, are you happy if I read from?
Sorry, Celeste, I was on mute.
Oh, no problem.
I'm happy to present, yes. If you
Okay.
can share our Matthew's discussion with us.
Oh, no problem. Yep. I can actually share the screen.
Okay, thank you. Matthew have been involved in quite a few, many outbreaks and different roles in different outbreaks that he was involved in. So, but in the discussion, he talked about his involvement in polio outbreak and not really they have a case that he was involved in, but with malaria, yes, he was actually involved in malaria outbreak. So in the first polio outbreak, he was his role in that was team leader in that polio outbreak back in the province. So uh, like I said, they did not have a case, but they were just in the planning, more of doing surveillance for the province. So upskilling of facility staff. So when there was a report that case problem was declared a polio, confirmed polio, then from NDOH message down to all the PHA. So that's where he got the message at the province. Then they called up district officers back to the province, run the training for the staff, mainly on the surveillance part, going through AFP forms and all this, how to collect specimens, and then beef up on the prevention measures, mainly on immunization campaign and all this, and risk communication in the communities, also educating, healthcare workers, sensitize communities with the knowledge on polio so that they also, keep watch of any suspected cases, then notify healthcare workers and then inform, and then if should there need be sample to be collected, then collected. So it's just generally with his participation in polio outbreak was just a surveillance and monitoring of any possible outbreak of polio. Okay, the second outbreak that he was actually involved was malaria outbreak when he was a clinical lecturer at one of the health centers in Karawaki district. How he detected that outbreak was through reviewing of the medical records. So that's how they identified, detect that there was an outbreak of malaria. So that was around comparing the monthly figures in March, April, they saw that there was a increase in malaria cases above what was the expected number. So through that records and also from the clinical presentation that patients present at the facility, it kinds of confirm their thoughts that it was really an outbreak of malaria. So what they did, they set up the investigation team, and then they went to that area, collect specimens. They also give a mass treatment to the people, also prophylaxis, and then collected samples to confirm those who came in sick who had fever. They collected the samples, sent it for laboratory testing, and all were treated with anti-malarials. Those who were positive. From that response, during the outbreak and during the intervention, there were like few deaths before they intervened. So once the team were out in the field with their control measures, they were able to reduce the severity of the cases, and they were able to reduce deaths too during that outbreak. So their main prophylactic prevention measures were anti-malarial treatment for those who were sick, prophylaxis treatment are not sick in that area that had the community that had the outbreak, and supply of bed nets, treated bed nets, community risk communication in the community, inform them of the primary health care, basic cleaning of the place, and all this to destroy breeding grounds for mosquitoes and all this. So yeah, okay. And the key challenges that during that outbreak that they were encountered were key challenges where they realized that healthcare workers with lack of knowledge to identify and cases of malaria, like islands, malaria is not endemic, so it's not they don't see cases like the coastal where it's been all the year round. So like patients present, we know that it's malaria, but islands is not endemic. But when you have, with that higher cases, it's possible outbreak. So healthcare workers, didn't have basic clinical information about malaria. That was one of the challenges, that health workers were not able to identify and detect malaria cases quickly, and then so that they can alert the authority if they see that, okay, there were too many cases than they expected. So without that knowledge, they thought it was just a mild fever only, so maybe they were treating them symptomatically. Okay, the other challenge that they faced was geographical challenges. Some of the areas where they were unable to reach, and also during that time in 2005, communication was a problem because we didn't have mobile networks this time. Around that time, only we were using like landlines, and it's usually at the provincial level and some few districts. But back in the communities and villages, communication was really a challenge for them, especially like during emergency. It's really hard to communicate. And how they overcome those challenges, Matthew mentioned that because of communication barriers, they had to allocate 1 or 2 vehicles to do a daily run, so that to bring in reports, and if there are any shortfalls in their medical supplies, then the transport is there too. And all, yeah, transport was there to help them during that time because of communication issues. Yeah, I
Great,
think that's all,
thanks.
Celeste.
Thanks.
Benny?
Thanks, Team 1, for that review. Let me just quickly share the screen for group 2. We had quite a bit of experience in this group, actually, with doing investigations, cholera, measles, malaria, pertussis, and of course, COVID. As team leaders, mainly doing that response, but also some out in the field. And it was interesting just hearing the kind of the steps that were taken by each of the investigators in the response. And we'll be going through this shortly, but quite comprehensive. And it was really nice to see some real focus on community engagement work, both with COVID as well as an example of doing, what was the other one? Cholera was another example. And some good interventions that were described for malaria and for cholera and for COVID, describing the different activities. And the challenges were the speed of response, and that was largely due to logistics as well as getting funds released to enable the response. Communications was also mentioned, as well as some challenges in implementing the interventions, the acceptance of interventions, both for malaria and kind of the use of bed nets, as well as for, of course, for COVID and the resistance to the immunization. But anyone on our team 2, would they like to add anything to that? good discussion around the importance of getting a team together before deploying. And Robert was mentioning the checklist that they have, a pre-deployment checklist that they work through. All right. Well, thanks everyone for that discussion. That was really, really helpful, and a ton of experience on the team that we were having this FETP cohort coming in with a lot of really great experience. So it's going to be a real interesting cohort to work with. So Bernie, we actually have a 5-minute break in our schedule right now. So did we want to take that 5-minute break and then we come back and we're jumping right into some content, outbreak content?
Yeah, okay. If the fellows are okay, if otherwise we continue or just take a 5 minutes break.
Yeah, we'll take a real quick break just to run to the
just quick break.
washroom, get some water, coffee, tea. Don't sign off, just keep logged in, and we'll put our videos on when we're starting, so you know it's time to connect back in. So it's 10 past the hour, so very short break, 5 minutes, just quickly run, do a couple of things and come back. We'll see you very shortly.
Thank you.
Thank you.
Thank you.
Don't go away, just take 5 minutes break, stand up for smoke or white break, then come back.
All righty, Bernie, are you there? All right, we'll make a start in a second as soon as Bernie joins us. Hopefully others are back online as well. Are you there, Bernie?
Yes.
Thanks, Philip. So Philip and Raphael are both back online. Thanks, George. George is back. Just waiting for Bernie and we'll get started.
Thank you.
Dia, are you on at all by any chance?
Hi.
Hi, Dia. Is Bernie with you?
Yes, she's here.
Okay. So Bernie, did you want me to jump in
I
and
think
do?
she's on mute.
Oh, okay. You're on mute, Bernie.
Hi. Yeah.
There you go.
Okay. I can James, I can talk about the introduction, definition, and types of outbreak,
Okay.
investigation, and case definition, and then you continue with outbreak investigation steps.
Yep.
And then case study. Is Celeste comfortable? They will break out again into breakout rooms.
Yeah,
Yep.
that's fine.
Yeah, and then you continue with communicate findings, just 1 or 2 slides only. And James, you talk about the investigation report, outbreak investigation report, plus the situation report. If
Yep.
that's
No
okay.
problem.
Thanks.
Sounds good.
Okay.
Sounds good, Bernie. So I'll share this screen.
James and Perry, sorry, it's Gilbert here. From time to time, I might be moving in and out. Sorry, I've got pressing things that I need to attend, but I'll come whenever I'm free. I'll sit in and listen. Thank you.
Yeah, no worries, Dr. Gilbert. Okay, Bernie, over to you.
Okay. Like I've mentioned, we will go talk about the common terms that we use during outbreaks. Next, please. Okay, so these are the some terms that normally, we use during outbreaks, But in this session, we'll look at the 3 ones that highlighted red: outbreak, epidemic, pandemic, but not more cluster and endemic. But in the face-to-face workshop, we'll go through all the terms together again in detail. Okay, before we move on to the case definition, can anyone tell me what the outbreak mean, or epidemic and pandemic means? What do all these terms mean? Hello?
Yes, hello.
Okay, Matthew, what is an outbreak? I know you have a
Outbreak,
lot of experience in that field.
yeah, outbreak is when there is a drastic increase, or other the definition of other like polio that you have cases that is beyond expected limits. So that's what an outbreak is. So it depends. It varies from disease to disease, especially on the infectious disease or other public health events. So it depending on the minimum required cases, and beyond that, we classify this as outbreak. So in a given period of time.
Okay, good. Okay, James, next slide, please. Okay, so Matthew have already also highlighted the what an outbreak is. So outbreak or an epidemic, it can mean the same. So it's an occurrence of a disease or diseases or health events that's higher than the expected baseline pattern. You may have like 2 to 3 times higher with the same disease or similar symptoms. Case similar to Matthew, how they recognize the malaria cases. So it was like 2 to 3 times higher than normally see. So they were able to pick that up and identify that malaria. So malaria was picked. They see that it was higher than what they usually see. Next slide. Maybe next. So epidemic can be used to mean the same thing as an outbreak, but it generally refers to a larger outbreak over a wider, you have a wider geographic area. So this means that you need to, the number of cases. You need to know the number of cases and the expected number. Like Matthew present with his experience with malaria cases. They at 2 to 3, 20 to 40%, that's what Wesley said, above what they usually see. So from that, they know that, okay, it's higher than they expected. And that's how they identified and detect malaria outbreak at the district. Next, please. Okay. Pandemic definition. Okay, pandemic is also a type of epidemic, an epidemic with enormous scope. Pan in Greek word means all.
Oh.
Yeah, so it's used as a prefix, but it helps us to understand the word, how the word, pandemic comes from is pan from the Greek word meaning whole. So like, by definition, pandemic is an epidemic that occurs throughout an entire country or continent or the entire world. So a classical example is what we're experiencing now, COVID-19, and yes, and there was yes. So an example of a pandemic is COVID-19, and there was also the one pandemic in 1919 was influenza pandemic that affects the whole world. Next. Okay, there are some exercises. You will not break into group rooms, but just show slides and you look at those graphs and you say whether this is an outbreak or not. You can describe that. So which of these could be outbreaks? It's just open discussion. A, national cases of X from January to July. Look at the graph A. What's the name of that graph?
Bar graph.
Huh?
It's a bar graph.
Okay.
Or should it be a column? Column graph?
But it's all joined together. So does that graph shows does that shows an outbreak or not?
Yeah, there's a outbreak in the
Okay,
dates
just one
of
talk first.
there's high increase of cases in the dates 19 to 20, 25, somewhere there.
Yeah, happy week number. So this graph is a happy curve of a possible outbreak. Yeah. So from week 19 to 25, okay, there was increase. George, you mentioned that.
Yep.
Increases. Okay. So like in general, does that graph indicate a possible outbreak?
Well, there was health events taking place in maybe in one catchment facility. That's why number of cases was detected. So possibly if it was going to, if that number of pattern was going to be detected in another week, that lead to disease outbreak. So I think it's a disease outbreak.
It is. Remember the definition. They've
Yes.
you see from say week 1 is like 60, count week 3 is like 70. Okay, it was steady, and then by epi week number 19 it went up to 120, and then week 20, 21 it went up to 160. So it kind of like double, triple up. So that's an
Triple up,
indication
yep.
that's a possible outbreak. You see, it's
Yes.
2 to 3 times higher than the expected. See?
Yep.
So yeah, so that graph A shows that it's a possibility of an outbreak. Okay. Graph B.
Yes. Graph B is also a outbreak.
Yes, okay. C. Is this an outbreak or?
Yes, it's an outbreak.
It's an outbreak.
Because there's no cases and then suddenly you have
there's an sudden increase of, yeah.
How many cases?
Just one case.
One case.
What type of disease?
Yeah.
What type of diseases? When you have one case, is an outbreak.
Cholera.
Polio.
Yeah. And maybe
like in
measles.
case of Papua New Guinea, measles,
polio,
cholera, polio. Okay. Remember those 5 agently notifiable conditions.
yes.
Yeah. Any one case detected, it's an outbreak. You don't expect more than one case. Okay, D.
B is a clear outbreak.
Clear example of an outbreak.
Okay. Okay, good. James, you want to add on? Next.
All right, so sorry, couldn't get off mute, but let's go to the next slide.
So all these four graphs there shows an outbreak.
Bernie, we established everyone discussed that it depends on the disease, doesn't it?
Yes, the outbreak depends on the disease. You are right. Thank you, Celeste. Like for that one case in graph C, like for measles, polio, cholera, one case is an outbreak. For A is example, like I gave like example like malaria. You have cases, but if it is 2 to 3 times higher than that the expected, then it's an outbreak.
Outbreak, yeah.
Yeah, the key thing is, the disease. So there's different thresholds. And also the other key thing is knowing what is normal. That's really the key question. What is the expected number of cases? What's the normal number of cases you see or expect to see? So in that first graph, like, what would be the normal number or the expected number of cases that you would expect just based on that graph? Approximately how many cases per week would you expect for this disease?
62, around 60 to 80.
Yeah, exactly. Between 40, 50, 60, 70, maybe.
70.
So hovering around that, and then
something higher than that is,
yes, higher than expected is, that's when you say, yep, that's an increase above expected, so we got an outbreak.
And you also need to be careful that what you are seeing is an actual increase in numbers and not just an increase in testing.
Yep.
Yeah, that's a really good point. So the next question is, to verify that outbreak, whether it really is truly an increase in cases, or, as Celeste said, maybe new testing method, or maybe a new health center opened, maybe influx of population into an area due to a flood or something. So all these questions may help explain that increase. It may not actually be a true increase, may not be an outbreak, may just be what we called an artifact, like a fake increase in some ways. And yeah, there's one in number D is a little bit harder to detect, but you can see it's a gradual increase over time. So we probably need to have a bit more data here, maybe another year or two worth of data, but it certainly looks like typically you expect, 5 or so cases, and then we've seen a gradual increase over many months, but it's certainly looking quite big, like it's 4 times higher, like in May than it was in January, so of the previous year. So it's looks like there's something going on there. Thanks, Bernie.
Okay, next. So why do we investigate the outbreak? What are some of the reasons? So firstly, someone want to say something?
Oh, Bernie, I just saw George's hand go up, so I just wanted to quickly check in with George to see if he wanted to add something.
Yep. Sure.
Oh yeah, okay. Going back to those 4 graphs, I just like to, get some idea as to how, in what situations such graphs would pop up. Looking at D, I'm just thinking that that kind of graph would show in such situations like there's tribal fight or some kind of war going on, and then there's be a lot of refugees camping up, and then lots of diseases coming up at the same time. And then looking back at the graph A, where there's lots of health issues going, and then at the same time lots of so I mean, just like to get some idea. This kind of graphs normally shows up in situations like where there's lots of refugees camping, or due to war or something like that, where there's limited health, or I mean, there's increased risk health activities taking place. Or I'm not sure, but I'm just trying to get some idea from whether this kind of graphs pops up in those places, or can it be occurring from any other places?
James, I can say something and later you and Celeste add on. Okay,
Sure.
Different outbreak investigate. What we see here is called the epicave. In any outbreaks, you have to, you know, collect your information later. I will not touch on that, but during the outbreak investigation steps, which James will present, we will discuss on that. But any outbreaks that it depends on the type of outbreak. So the one graph may not be the same as in one outbreak be the same as in other outbreak. It depends on the presentation of cases during that outbreak, the number of cases that you collect that meets the case definition for that outbreak period. And yes, and then your response measures, the control measures that you intervene. Once you intervene, you will see a decline in number of cases. The graph will, like for example, A, it drops down, or in graph D, you see it eventually go up. Maybe they pick that, and then once they introduce the control measures, and then it slowly slopes down and then down. So each graph will depend on the type of outbreak and how fast the response team, intervene and with their control measures to control and the cases. So here the epicave usually shows, it talks about the number of cases captured during that outbreak or identified during that outbreak that meets the case definition for that outbreak or disease that caused the outbreak. And then
Thank
when
you.
you analyze, put them in table or Excel, and then it gives you this type of graphs. But one graph may not be the same as one graph for that outbreak. The epicave for that one outbreak is not the same as the epicave for another outbreak. So it depends on its diseases. How you identify, detect the case quickly, you respond and control. So James and Celeste
All
can
right.
add on.
All right. Thank you.
Yeah, sure. Did you want to add anything, Celeste?
No, I think.
James. Sorry, James Gilbert here. Can I add something?
Yeah, sure.
Okay. I don't know. I'm trying to upload a slide, particularly related to the one you put on the slide D, just to explain that this can be recurrent. So if I can share a slide, let me see if I can try. I know I cannot do it. So
try now. Try now.
Okay. Like this one. Can you see it?
No.
Can anybody see it?
No.
Can anybody see this slide?
Not yet.
No.
Nope. Not yet.
No.
It's a PowerPoint slide I was trying to share. Let's try again. Now this one. Can anybody see it?
You go share.
No.
I'll go to what? Share?
You go to share.
Share screen.
Yeah, you go to share. Click the green one, share, and then you
Yeah,
click on the PowerPoint, and then click the blue one, share.
Oh, okay.
Yep.
I got the one, so I'll go to the PowerPoint now. Sorry,
And then
be patient with me.
Then press the share in blue dot.
Yeah, I know. I'm looking for, where did I lose this one? Pull this one out again, sorry. You can see this one, can you? Okay, let me quickly.
No.
Let me quickly check. Just wait patiently. Give me a few minutes, sorry.
I wonder whether we should go to Joachim with his hand up while we're waiting for Gilbert.
Yeah,
All right, you
Joachim.
do that. Yeah, go ahead. For the guy, go ahead. I will, as soon as I'm ready, I'll let you know.
Joachim, go ahead with your question or comment.
Thank you. I just want to go back to the screen in regards to the graph, the epi curve. I just want to comment on the answer C and D. I see that it shows one case of a disease that pops up during that period, January to April, for the case Z, and that also is also an outbreak for that period. Whereas for D, it's more or less like a surge in a period of time from from January 16 to April, as we can see from the screen. And I see that from a particular time, the number of cases has gone beyond expected, so it's gone up. So there's a sequence of those diseases popping up from time to time, and then goes up much further up, and then declines again to a certain level, which shows an outbreak, but probably a surge that comes on and then probably goes off. But it can only be controlled and indicated in the graph when we actually control the disease outbreak in a particular area that is indicated by the graph. So I just want to comment on that. I'm not making a suggestion. I just want to comment on that because from the COVID-19 experience, we've seen a lot of surge so far in our graphs going up and then comes down and then in a certain level and then it goes up again when there's a surge in a particular time. Thank you.
Yeah, thanks, Joachim, for that reflection. Yeah, and the epi curve, it shows the increase and then the decrease of a disease, and the decrease may be the result of an intervention that you've done as a field epidemiologist or as an investigator. It may also just be the natural cycle of the disease. It will generally burn itself out in a population if it's not controlled. Eventually, the full number of people will get the illness, and then they may get some immunity from that natural infection, and then it will slowly decline as well. But looks like, Dr. Gilbert, you've got your screen shared now.
Yes,
so.
Yes.
Go ahead, Dr. Gilbert. Did you want to comment on this one? Dr. Gilbert, you're on mute. You're on mute.
Okay. Can you hear me now?
Yes.
Yes.
Okay. What we're trying to refer to slide D. Sometimes you have what they call diseases that occur during decisional area. Each year, each month, you see such a surge of, like this is the flu. Tata case admitted with pneumonia, cases admitted over time from 2015 onwards. We try to see if there's a sequence of events happening every 2 months, or like when it's in winter in Australia, we have such of increase in the flu cases and cough cases. So that's, it does comes in sequence of seasonal, like referred to the graph in D. That's why I want to show you the slide. Over time, if you analyze time, data over time, you can see the sequence of events on why you have certain stages of cases. So that's why I want to show you to explain the slide D. And then also this is the outpatient cases, similar timeline. Like in around March and May, you see a surge of cases. And then every March or May, you see increase because of seasonal variation. So over time, you can say that it's not the truth. Sometimes you see a huge outbreak, this outbreak, but over time, certain events, certain timeline, you see some increases. So this is the true data of PNG, of the NHIS data on the number of flu cases, number of cases outpatient on, we see it in 2015. Just to show you the trend, that's why I want to show the slide out for me.
Thanks, Dr. Gilbert. That's a really good point.
Yeah,
And
thank you. That really helps.
yeah, that seasonality, let's go back and have a quick look again at slide D. And you can see what Dr. Gilbert's saying here. This could be a seasonal pattern, and we see this increase kind of happen every couple of years. So before we get too excited that this is an actual outbreak, we would want to look at a bit more data, a bit data more early, just to see whether this same increase kind of happens all the time. And if every couple of years in May, we see an increase of up to 20 cases, then this is an expected number of cases, right? If this is a cycle that we see, and at this point, we expect this number of cases, then it actually may not be an outbreak because it's not above what we expect for that time of the year. So that one, D, could be an outbreak, but it may not be. We need some more data. We need some more data on that one. Did anyone have any questions about that or these, what we call epi curves, epidemic curves? Any questions? Yeah, each of these bar graphs represents a disease or a syndrome, and it represents the number of cases by that time frame. And it's a visual way of us knowing if there's an increase and it's an outbreak, and it may trigger us to investigate. So an epi curve is something that all the field epidemiologists will learn a lot about how to do them. And it really is something that should be included in every outbreak report. You have an epidemic curve, an epi curve, one of these bar graphs in your report. Okay, thanks. Over to you, Bernie, to continue. Let's get on to the next one.
Okay, what are some of the reasons why we do outbreak investigation? George, Joachim, Raphael, why do we investigate an outbreak? Okay, let's go. Next slide, James. Okay, basically, objective of investigating an outbreak is basically we want to stop the outbreak and prevent the spread of the disease with the immediate control measures. So control measures depends on the type of outbreak. So not all control measures is the same for all outbreaks. Secondly, to improve understanding of the disease, from the discussion, with outbreak, that's the opportunity we upskill, run trainings or refresher workshops to upskill staff to, understand the disease, how they spread, mode of transmission, and all this, so that this will help in future control. Staffs are well equipped with the knowledge and the skills to know how to do so. Any future outbreak of that of that same disease, they know how to go about to control that outbreak. It also saves resources when we investigate the outbreak quickly. It saves money, and the health workers doesn't, get overworked or, all this. So we contain the outbreak before it gets out of control. So when it gets out of control, you need more resources in terms of finance, material, and manpower to work to control the outbreak. The other objective is to test and to help us to improve our surveillance and response systems. Now with this COVID-19, we can really see that our surveillance system is a bit weak. So when there is an outbreak, it's also kind of like a pushback on us, kick on our asses to stand up and activate our surveillance system. We must be always, be vigilant and improve and strengthen our surveillance system. That will help us to, identify or detect cases, and then provide training for junior staff in public health investigation and emergency response. For example, we've been running RRT training to some of the provinces. We're trying to build, staff capacity on the ground to respond to any outbreak or public health emergencies that is occurring. And we want to do the right thing, politically and legally. So these are the objectives why we are investigating outbreaks. Next, please.
Case definition and detection.
So outbreak is, Celeste, would you like to take on that?
Yeah, thanks, Bernie. Not a problem. So what we need to do in an outbreak is, of course, define what a case is so that we can start building a picture of what the outbreak looks like based on what we think the case is. So defining the case is different for an outbreak as compared to routine surveillance. So if there's an outbreak, you might need to make your case definition a little different from what your surveillance case definition is. So basically, we define a case by person, place, time, and illness, depending on the setting. And it's not necessarily just a clinical diagnosis. You need to bring in epidemiological factors as well. So where you would expect cases to be, what type of people are getting infected, and also at what time. So there we go. We go into those factors on the next slide. You need clinical criteria, and there's also different tiers of case definitions. So you might have a confirmed case, you might have a probable case, and a suspected case definition. And the confirmed case is often, but not always, because you may not know what the disease is yet, linked to some lab results, and sometimes some other clinical criteria, nausea and vomiting, diarrhea and/or vomiting, something like that, depending on the disease. And in terms of the epidemiological information, again, you want to define what kind of people. Is it only in children that this outbreak is expected? Is it in a defined geographical space or in an institution, for example, in a nursing home or a school? And you also need to define the time from when the outbreak was thought to have begun. Next slide. Okay, back to you, Bernie.
Thanks. Okay. Before we go to the outbreak investigation steps, we need to, how do we know if there is an outbreak? So we find out about possible outbreaks through two types of surveillance. James, I wanted to ask before you click, just to refresh back to the introduction to public health surveillance, the types of surveillance. Hello.
Yes, hello.
Okay, how do we find out if there are possible outbreaks? Okay, we said two types of surveillance we can help us to know that there is an outbreak. Okay. It's okay, James, we can continue.
Yes.
Joachim, you raised your hand. Is it a new hand? You want to say something? James next. Okay. Thank you. Okay, so we find out that possible outbreaks through two types of surveillance here. Indicator-based surveillance, mainly we talk about, for example, the ENHIS, the routine surveillance, regular collection and analysis of health information data that we collect from normal routine outpatient cases, or like other diseases like Malaria is also doing its report, or TB doing quarterly report. These are regular routine surveillance reporting. And then we analyze that in graphs, and then we see if there is a possible outbreak. So reviewing of medical records from the routine surveillance data collected. Or the second one is through event-based structure. And it can be reported through, reports from the community, or just rumors from the community, or from the social media through newspaper or Facebook or WhatsApp, or through observation from the laboratory that they identify that, okay, that organism that causes this disease which is potential for outbreaks. Or as a clinician at the facility, from your observation, seeing cases coming in, that's a new signs and symptoms a patient is presenting, which you have not seen this type of case before. This could be one of these cases could be a possible outbreak. Other sources of alerts that you can also suspect, or is from any religious organization or people, in the community, reporting to you, or any, like back in the village and our communities, we have these traditional healers, or any NGO organizations that are, sending you some message or reports, or from veterinary authorities, any possible outbreaks from animals that can eventually affect humans, or any other authorities like environment or agriculture, food and safety, all this. So event basis depend on what event is happening, and then there is a possible that can cause outbreak, and the information is collected from all these different type of sources. So based on that, then you may suspect it may be probably lead to an outbreak. Okay, James, next is all yours.
Great, thanks, Bernie. So we're going to go through the 8 steps in an outbreak investigation, but any questions before we move on? Any questions on case definition or on detecting outbreaks through these 2 types of surveillance? Yes, Joachim.
Yes, thank you. I just want to ask a question. If in a situation where we have an event of a particular disease outbreak with an unknown case definition to that disease, do we have to create our own case definition for that, according to what you've hinted us through your presentation on the epidemiological aspect of it and clinical, or do we have to refer to experts to standardize it So we can base our case definition on that particular outbreak.
Yeah, great question. Thanks, York. And Celeste, did you want to answer that one, or?
Yeah, sure. So really, Joachim, thanks for the question. Really good one. You really need to make your case definition specific to your outbreak. So it does need to be locally adapted, probably from some kind of standard. So you might have a surveillance definition. Say there was an outbreak of pertussis, you would have a surveillance definition for pertussis across PNG, but perhaps you have an outbreak in a school. So in order for you to investigate that particular outbreak, you need to narrow your definition and include factors in that, such as the children within that particular school, or if you want to make it a little bit wider to make sure that you capture everybody, then you might want to just look at it in a particular village. Catchment, exactly. Does that answer your question?
Yeah, thank you. I think that is okay. So we have to have a collaborative views on how we could create our case definition, probably from the lab people,
yes,
the surveillance people, from some other sources. We could collaboratively put all our efforts together to design our case definition for that particular one.
Yes, exactly. So it's a collaborative effort usually. Once you've put your team together and you've done some preliminary investigation, that's when you come up with a preliminary case definition, which can be revisited and redefined once you've gone out and done some questioning of some of the cases. You might want to redesign your case definition and refine your case definition once you have more information about it.
Thank you, Celeste.
James, do you want to add, or Bernie?
No, that's a great answer, and yeah, this training, like field epi training, is going to really put you in a good position to be able to create these case definitions. They're not always easy to do, but it is good to have that collaboration. But I think as field epidemiologists, you'll be the ones who will be looked to create an outbreak case definition. So you've rightly recognized the difference between a surveillance case definition. Now, a surveillance one is typically designed or put together at a national level.
National level.
Yeah, and it doesn't ever change, or very rarely changes. So it's national, it's defined, and it's put together through an expert group, etc. But when it comes to outbreaks, especially those within your jurisdiction, you're the one responsible for making that definition. And as Celeste said, it will probably change over time. When you get more information, you can actually change your outbreak case definition to make it more specific. And we'll be looking at this in a lot of detail next year in our face-to-face workshops. But the key thing is an outbreak case definition is always developed specifically for that outbreak. So you can't use your outbreak definition, that you used last year. You can't just reuse it this year. It's got to be specific to that specific outbreak because it has components of person, place, and time in that outbreak definition.
Thank you. Thank you very much.
All right. Let's keep going here. So the 8 steps of an outbreak investigation. Now, these steps are really, really helpful. Sometimes when you have an outbreak presenting to you, it can be quite overwhelming, especially if there's a lot of cases or there's severe illness or if there's deaths. You can get a little bit nervous about, oh gosh, like what do I do? And as an epidemiologist, people will be looking to you for leadership on how to investigate outbreaks. And having these 8 steps to think through really helps you do it in a systematic way. It makes it less intimidating. You'll be less nervous doing an outbreak investigation when you have these steps to follow. And it was really interesting during our breakouts. People were describing the steps they took, and a lot of them were covered. But what I think we're going to do through this training, this field epidemiology training, is we're going to make your investigations more complete. We're going to make sure you're not missing any steps. And we're going to put a lot of emphasis on your data, evidence-based data decision-making. So you saw the epi curves. This is just one part of the data side of an outbreak investigation. It's collating, collecting that data, is interpreting it, analyzing and interpreting it, and then basing your decisions on the data. So this is going to be a big focus going forward for outbreak investigation. So let's have a look at the steps. These are the 8 steps of an outbreak investigation. And we'll kind of go through them as an introduction in this session, and we'll be looking at them again when we come face to face. Now, the control measures, you'll see there is a step number 7. And I just wanted to emphasize that control measures actually can take place at any point in the investigation and should actually happen as soon as possible. So even though it's listed as step number 7 there, often control measures could be implemented early, and then you continue your investigation, you get more information, you analyze it, and then you might change your intervention. But it's best just to try to do it early, because the main goal of an investigation, of course, is to prevent disease and prevent death. And it's all about speed. For outbreak investigations in the field, is all about getting into the field quickly so we can prevent as many cases as we can. So these are the steps: confirm the outbreak, establish the diagnosis, make a case definition, outbreak case definition, find our cases and get information from them, make a line list, and we'll talk about what a line list is, describe and interpret the data, so there's analysis, implement control measures, and communicate findings. Now, these 8 steps kind of fall into 3 different categories, or 3 different questions that we're asking. So we have these 3 questions. The first question is, is there an outbreak? And if there is, what's the cause? So some of those steps are going to answer that first question. The second question is, what factors are contributing to the outbreak? So what's causing this outbreak? What are the risk factors? So that's question number 2, and there's some steps that will help answer that question. And then finally, what actions can we take? What's our interventions? What can we do to stop the spread of the disease? So let's break it down. So this is our first question. Question number 1, is there an outbreak? And if so, what is the cause? Now, the first step is to confirm the outbreak. And that is because we don't want to get all excited and hire helicopters and spend a lot of money getting into the field just to investigate a rumor that actually turns out to be nothing. It wasn't really an outbreak. And it's important to take a little bit of time just to confirm the step before we launch into an investigation mode. So these are some of the things we may want to consider. Are the reports coming in to us from surveillance or from rumors? Are they accurate? So we need to double check. We need to check that the surveillance data wasn't a mistake. People didn't do a accidental 100 when they really meant 1. We need to just confirm and validate the data. We might want to confirm the report that came in from the field. So we phone back if we can, make contact. We ask some good questions to help us understand, is this truly an outbreak? The second question we ask is the number of cases that we're seeing, is it much greater than what we expect? So we need to know what we expect for that disease. And to do that, we need to have surveillance in place. We need to know, okay, well, we normally expect 5 cases a week. We're seeing 100 cases. It's clearly an increase above expected. So it's likely to be a true outbreak. If we don't have good surveillance, we may just have to talk to people in the field to get an idea of how many cases they would normally see of this particular disease. And they'll be able to tell us if it's above what they expect. Do all the cases have the same illness? Now, this can be a tricky one because there could, by chance, be 2 things or 3 things happening at once. They may be similar illnesses, but they're completely different sources. And when we put them together, it makes it look like there's an increase, but there's actually multiple things just happening at the same time by coincidence. Is not the same illness. And often we get this, so we get a phone call from someone from a health center out in a rural area saying, oh, we've seen 3 deaths over the past 2 weeks. We have something going on. Please come and investigate. And then when you ask your good questions as an epidemiologist, you ask, well, explain what the symptoms were for each of the cases. And you'll be asking more questions about the onset of the disease and the length of the illness and the symptoms they had. And you may find out that these are really looking like 3 completely different things. So even though they're clustering together, making it sound like it's unusual, they're not connected in any way. They're different things happening, so we may not have an actual outbreak. And has the reporting or testing remained the same? So of course, if you introduce a new rapid test kit looking for dengue, for example, in the past they weren't looking for it, or they were using other very slow methods, then suddenly you're going to see a whole lot of dengue cases coming through because you have a new test that's able to detect it. Doesn't mean there's an outbreak, it just means you're finally detecting the cases that were always there, but in the past you were unable to detect them. And then the second step is to establish the diagnosis. And this means trying to get a really good understanding on the symptoms and the syndrome, and if possible, to get a specimen collected for the laboratory to get a confirmed diagnosis, a laboratory diagnosis. So to do these 2 steps, you may need to phone people, you may need to look at records or surveillance data, you may need to go into the field. So that's the first 2 steps. And let me just pull up. Please put up your hand if at any point if you have a question, and we'll pause so you can ask your question or make a comment. If I don't see your hands go up in the chat or the participant list, we'll just keep going. All right, so second question is, what factors are contributing to the outbreak? So this is the fun part, is, okay, what's causing it? How can we stop it? So making a case definition, making an outbreak case definition is a really important first step. Does someone want to tell me why it's important to make an outbreak case definition and not just jump in and start investigating? Why is it important to create an outbreak case definition? Joachim, you got your hand up. Just unmute yourself, Joachim. You're on mute.
Thank you. Thank you.
And George as well after. So Joachim, then George. Thanks, Joachim.
Case definition would be a guide, and also a definition that will confine us only to whatever disease outbreak in that particular time.
Yes, good. I love that definition. Thank you, George. You're on mute, George.
Oh yeah. Okay. The case definition will definitely give you assurance that you have the disease outbreak or not. If whatever things that you're finding out from your investigation, you find out that it's not meeting the case definition, then it's not a disease outbreak. That's what I understand.
Yes, thank you, George. Did anyone else want to make a comment? around why we need to have a case definition in an outbreak. So both Joachim and George hinted right at the correct answer. We want to be really sure when we do our investigation that the cases that we're investigating are part of the outbreak that we're interested in. Because there may be some unrelated cases with a different disease or something different going on. And if we include them in our investigation and we ask them questions around their risk factors and they're not related to the outbreak we're interested in, then we're going to make our analysis really complex, and it's going to be really messy because we're mixing true cases that are part of the outbreak with cases that are not part of the outbreak. So all their risk factor information is really irrelevant to us. So when we start including that, we're not going to find the true answer from our analysis. So we want to make sure we only include cases that we're pretty confident that are part of this outbreak. So that's why we have a case definition. We define our cases by the syndromes. So they all have to have the same syndrome, or they have to have the same disease if we're doing testing. And more than that, they need to be also connected by person, place, and time. So they need to be cases coming from the same region. That's our place. They have to be coming from, they have to have their onset dates within a specific time frame. And it could be a particular type of person, like a child in a school, or it might be more defined based on the person criteria. Just these things help us build our confidence that the individual that we're investigating is truly part of the outbreak we're investigating. Does that make sense for everyone?
Good. Yes, thank you.
Good.
Yep, yes.
Really important step, and often we skip this one, but a really important one to do. Step number 4 is to find our cases. So this might be going to the field and we talk to the chief, we have a meeting with the community, we get people to self-identify if they meet our case definition. Or if they have symptoms, they come forward and we ask them more questions to see if they are and truly a case that is part of our outbreak. It may mean going to the health center, looking through the register, finding out cases and identifying them through a register. Might be going into a hospital and finding cases that are hospitalized that might meet our case definition. So this is a really critical part of the investigation, is finding our cases, and then we collect information on those cases. What's the best way to collect information on our cases? Any thoughts? What's the best way to collect consistent information on our cases? We want to ask them some questions. We want to know, some of their risk factors, where they went, what they ate maybe, if it's a cholera outbreak, what they drank, where the water source is. What's the best way to collect that sort of information in a consistent, standardized way?
Develop a form.
Absolutely, yes. Develop a form, develop a questionnaire.
Consistent.
Questionnaire, yeah.
Yeah, and we have the questions because we want to ask the same question to every person in the same way. That's what makes a good investigator, a good epidemiologist, is asking the same set of questions in the same way to all the people. That's how we're going to get our answers to help us solve the investigation. So yeah, we create a form, a questionnaire, we collect that information, we put that information into a line list, and then we describe, interpret, and analyze the data. So a line list, I'm not sure if everyone would know what a line list is. So let me quickly explain. If you think of Excel, an Excel spreadsheet, and you can think of all the rows in Excel, there's lots of different rows. Each of those rows makes up a line. And what we do is we collect information about the case all on one line. So we might have their name, their age, their sex, whether the symptoms they had, the village they're from, whether they drank water from well A or well B. All this information can be captured in one line on an Excel spreadsheet or on a bit of paper. You can, same thing, you can have a bit of paper, you can roll lines across the page, and you can capture the information on each case on a single line. And we'll show you examples of this. And this really helps to do your analysis. That's why we put it into a line list. It's just a list line by line. That's what a line list is. And each line represents one case. Okay, and then we come to question number 3. We're implementing our control measures. Hopefully we've got some control measures maybe already in place, but now we've analyzed our data. We really have a good understanding of what the issue is. So let's think of an example of cholera. We've gone in, we've investigated our cases, we've talked to them all that had the same symptoms, watery diarrhea. We've asked some questions on where they come from, what their water source is, what their foods they've eaten, and we've come to identify a specific well as being the potential source of cholera. Therefore, we can get in place some really targeted control measures. We can prevent anyone taking water from that well. We can look at where it got contaminated, how it got contaminated. Was there a toilet nearby? Was there an overflow? We can investigate all of those things to make sure no more cases arise. And then finally, we communicate the findings. So we write up our outbreak in a report, and we can summarize the key information and we can share it back to the community. So the people that were involved, we need to tell them what we found. We can tell our managers and our officials. We may even tell the media if we have, it's a big issue that lots of interest, we could talk to the media. We might go on the radio, whatever. So we have to communicate our findings and tell people what happened and how to prevent it from happening again. Okay, any questions on those steps before we go on to the next section? Okay, good, thank you. And then I think we're going to go into have a mini case study where we'll go into our 2 breakout rooms again, and we use the same Word documents to continue on, and we have like a mini case study looking at an example outbreak. So we'll break off into 2 groups. I'll mix the groups up again. Celeste will take one group, and I'll take one group and take the notes for it, and then we'll work through the mini case study. And we might just make this 30 minutes, and then we'll have a break after that.